health and is here to pick up medication for her husband. Her daughter was recently diagnosed with breast cancer, and she wants to know how much longer she should continue to have her yearly mammograms. So, like I did last week, I'm going to call on people to help make this more interactive. So, Nabil, can you tell us what the answer is for this question?
I believe I put A.
Okay. So if she has a life expectancy of 10 years? Exactly. Yeah. Exactly. Because, we kind of talked about this last week about, when patients get to a certain age, if they're not really in good health and if it's not expected that they're going to live for 10 years, there may not be a viable reason to continue to have mammograms. They're not an invasive procedure. They're not like colonoscopies or anything like that, but they do expose a person to little bits of radiation throughout their life. And it does have a cost to the system too, to do these mammograms. So, when people get to that kind of 75, 76 range, they start taking into account what other health conditions they might have. And if they seem really healthy, then, absolutely we encourage them to continue. Thank you, Nabil. That was great. All right. RD is a 55-year-old patient who recently discovered a lump in her left breast. After a diagnostic mammogram and subsequent ultrasound-guided biopsy, she was told she had a HER2-enriched early-stage breast cancer. A friend of hers suggested that she have her Oncotype tested as well. She's never heard of the test and asked for your recommendation. So before I have to call on anyone, is there anyone who would like to answer this? Because I know this is maybe a little bit harder.
Is it the gene testing where they test the genes to find out that will the patient respond to the treatment?
So that exactly describes the Oncotype DX test. Absolutely. But in this case, for this patient, would it be appropriate?
I think, yeah, she has a lump in the left breast.
So what information?
HER2. Mm-hmm, she has HER2 enriched. HER2.
Okay, so she's HER2 enriched. What does that mean? Does that mean, like, in terms of her receptors?
HER2 positive.
Right, so she's HER2 positive. Is she hormone receptor positive?
Can you say, okay. Sorry.
That's okay.
What did you say? What was your question?
Yeah, so the question was, so if she's HER2 enriched, does that mean she's also overexpressing the hormone receptors in her breast cancer?
Yes, I would say.
Okay. Is there anyone else who'd like to jump in and help out? Because I think there's one component we're missing here.
For the ERPR?
Right. So is she ERPR positive?
We don't know that yet.
Well, we do know though, right? Because she's HER2 enriched.
HER2 enriched, yeah.
Mm-hmm. So if she were ERPR positive, what are the two other kinds of molecular subtypes that she could be?
Are you talking about the luminal B and luminal A?
Yes, exactly. That's exactly what I'm talking about. So luminal A and luminal B, we know they're always hormone receptor positive, right? It's just that luminal B could be either HER2 positive or HER2 negative. But if you're HER2 enriched, that means you're overexpressing lots of this HER2, but you don't overexpress any of the hormone receptors. So you're going to be hormone receptor negative, right? And then if you're triple negative, what don't you have? You don't have any of them, right? Okay. So the kind of trick here is to recognize if this is HER2 enriched, that means the Oncotype DS is not appropriate in her case, right? So I know it's a little tricky because you're looking at early stage breast cancer and you're like, yes, early stage breast cancer, absolutely, she should get the Oncotype DX so that we can determine if chemo is appropriate. So I think it's clear that you all understand that Oncotype DX is used to determine, whether or not giving somebody chemotherapy in an early breast cancer is going to be really helpful. But in this case, we know that because she's HER2 enriched, it's not going to help us at all. Does that make sense?
So the DX is only to see if it's the hormone enriched. Is that what that test tells you?
No. So the Oncotype DX is it's a test, a genetic test to determine your risk of recurrence. Okay. Yeah. So when someone has a hormone receptor positive cancer, we've identified a series of genes that confer a risk of having a patient recur. And so for a patient who has an early stage breast cancer that's hormone receptor positive, so it doesn't matter about ER status, we're just looking at hormone receptor positive. We want to know if we need to expose someone to poison, right? Because these chemotherapy agents are poisonous. As you've gone through the lecture, you've seen that some of them can cause like cardiotoxicity and arrhythmias and all kinds of nasty stuff. So in order to potentially spare somebody who maybe is like low risk of recurrence, we use the Oncotype DX to decide if we need to expose somebody to all this crap. So it's a very helpful test. It's not so helpful when someone's kind of in the middle and they're intermediate risk. Then it's like you talk to the patient, and if they're amenable, you kind of encourage them. It's really easy if you're low risk or you're high risk. If you're high risk, we know we got to give you chemo. If you're low risk, we think we probably can just say, you know what, let's just do the hormone therapy and let's just keep continually surveilling you to make sure that you're not having a recurrence. Does that make sense?
Thank you.
Yeah, no problem.
Dr. Lee, I have a quick question. Yeah. So I just want to make sure I understand this. Since she's HER2 enriched, we know that she's ER/PR negative, so that's why we're not doing the Oncotype test. But
exactly.
If it were luminal A or luminal B, we would have done it.
Exactly.
Okay.
Luminal A, luminal B, and early stage.
Early stage. Okay. Thank you.
Mm-hmm.
A quick question, Dr.
Sure.
How, from reading that, how do we know that she was hormone negative?
So we know that she's hormone negative because she's HER2 enriched. So that's actually the definition of that molecular subtype. If you're HER2 enriched, you're only overexpressing. So actually here, I'm going to draw this out for you for a second here. Let me see if I can find my whiteboard. I'm going to stop sharing for a second and I need to take over as host. Sorry. Let me just do that quickly. Okay. Here we go. Oh, interesting. There it is. Okay. All right. So you've got a breast cancer cell. And I apologize for my rudimentary drawings here. Okay. And receptors are usually things that kind of stick off, and they have a extracellular and a transmembrane and an intracellular component, right? This is from biology many moons ago. Okay. When we look at, so let's say this is a breast cancer cell. When we are examining it under a microscope and doing genetic testing and things like this, we want to look to see what kinds of things are popping up on the surface and how much of them are popping up on the surface, right? Because every single breast cancer cell probably expresses some level of HER2, right? And some level of a hormone receptor. Because we know that breast cells in general, any kind of reproductive cells, respond to changes in hormone, right? That's just part of the environment. And so hormones will help let, different kinds of cell lines know, hey, I got to grow and proliferate under normal circumstances. But they're supposed to have mechanisms, right, that we've talked about, where they stop growing, they stop proliferating, et cetera. So what we do is we look under these like different kinds of techniques using FISH and other immunohistochemistry, and we look to see how many of these are being expressed or overexpressed every time we do the pathology, right? And if we see there are tons and tons and tons where they're overexpressing ER, for example, estrogen receptor or progesterone receptor, then we know they're positive. And that's when we do the Oncotype DX again for early breast cancers. For the HER2 enriched, again, we're just looking to see if these cells are being, or these receptors are being overexpressed at the cell surface membrane. Because we know that when these guys, HER2, for example, are overexpressed, they turn on all this signaling to tell the cell to keep dividing and keep proliferating. And that's why we have medications that try and shut down these receptors. Same thing goes for estrogen receptors, right? You give somebody tamoxifen, and that blocks off the estrogen receptors. It helps to downregulate them so that these cells are not expressing them as much. And that's good because we know that certain kinds of cancers tend to respond more, again, to having high levels of estrogen or other kinds of hormones. Does that answer the question? Or does that give you a little bit?
Yeah. I think what I was confused on was the HER2 positive. That means it's enriched, but just figuring out the difference between the estrogen ER positive and then ER negative versus the PR positive versus PR negative.
So for our purposes, we're grouping ER, PR together, right? So I'm not gonna, we're not gonna worry about if you're ER positive but you're PR negative, it doesn't matter because you're still gonna get hormone therapy. So I think probably the best advice that I can give to you for this is, unfortunately, memorizing the molecular subtypes is just that. It's going to have to be a memorization because it's going to make it a lot easier for you to be able to identify some of these cancers and what the appropriate drug treatments are.
I understand that part, but then when I was looking at that, it wasn't on this lecture slide, but it was on the prior one. There was an image where it showed luminal B, ER, PR positive, and then HER2 positive. But it also showed the HER2 positive and where it kind of differentiated out to the ER negative. So my question was, it was just hard differentiating the two between the two. Within this question, saying it's ER2 enriched. We know that's positive, but we don't know.
It's HER2 enriched. It's not ER/PR positive. And one thing I would point out to you to help, I actually posted a Word document or a PDF, I guess, of all the molecular subtypes and a breakdown to make it easier for you. So that may be, if you go back to Onc Day 8, underneath the materials, you'll see a molecular subtype description for all of them.
Okay.
So I would direct yourself back to that because then it'll make it a lot easier for you. Because it seems out of context. It's a lot to memorize. Does that make sense?
I'll take a look at that.
Okay, awesome. Yeah, and that's for anyone. Remember when I did the whiteboard session, I had said I would go ahead and post that after class, and so it is available. All right, if there are no more questions, we'll move on. So trastuzumab and pertuzumab in combination do not cause additional cardiotoxicity. Anyone want to help us out? Is that true or false?
Yeah.
It's true. That's right. Exactly. Just as a follow-up question, what kinds of medications are trastuzumab and pertuzumab? So what's their MOA?
HER2.
That's right. They're HER2 monoclonal antibodies, right? And they're humanized because they've got that Zumab. So what's interesting is that trastuzumab and pertuzumab, we obviously use if you're HER2 positive, right? And we use it kind of at different stages. Usually trastuzumab and pertuzumab we use in we use together in slightly later stages of breast cancer, although some of that's changing now. But one of the problems when trastuzumab first came out was we were seeing a lot of cardiomyopathy. We were also seeing a lot of asymptomatic, really big drops in a patient's echocardiogram. And so we recognized that this particular drug, trastuzumab, is very, very cardiotoxic, especially if you consider that a lot of these women are getting radiation to the chest. And even though we do a good job of blocking organs to help prevent the heart from being exposed to radiation, there usually is still some radiation that escapes and can damage the myocardium. So when trastuzumab first came out, we thought, if we're combining these two, we're going to end up having a lot of additional cardiotoxicity. And based on the Cleopatra trial, and there have been many iterations of that since, we really haven't seen an increase risk in cardiotoxicity. So, there's no real explanation for it. One of the reasons we combine trastuzumab and pertuzumab, because you're probably wondering, why are we using two anti-HER2 antibodies? Like, isn't that duplicative therapy? Well, the reason why we use them together is because they're actually synergistic. So what's cool about trastuzumab is that this monoclonal antibody comes and it sits down on top of the receptor and it tells the cell to stop proliferating, right? So it shuts down some of that constitutively active signaling that's inside the cell. And then where pertuzumab comes in is it actually dimerizes with that receptor on top too, and it causes a cell signaling cycle to happen that tells the cell to kill itself, to go into apoptosis. So what's really cool about using Herceptin and Perjeta together is that you're telling the cell stop growing and you're causing it to essentially commit suicide, which is what we want for these cells. All right. We good on that? Any questions?
How is it able to do that? Is it just binding to the different forms of the receptor that it's causing those two MOAs?
Yep, exactly. Oh. So it just has to, one of them kind of sits on top and just interferes with that transmembrane signaling. And then the other one actually dimerizes and some of it gets engulfed and it causes this like downstream, cycling of the cell to tell it to stop or to tell it to kill itself. It's really cool. It's actually a very elegant mechanism of action. And so again, that's why we tend to use it together, because one of the things that I talk to you about HER2 enriched especially, but any kind of HER2 positivity, what does that do for prognosis? Is it better to have HER2 positivity or is it worse? Do you guys remember?
Better?
It's worse, I think.
It's worse, yeah. So it's better in the sense of it's better than triple negative because we don't have any targets, right? And we know that triple negative breast cancers tend to be much more aggressive just in general. But HER2 positivity usually means that because it's part of the epidermal growth factor family, that really does help increase, cell proliferation. So that means that normally HER2 positivity breast cancers tend to be more aggressive than just an ERPR positive breast cancer. And they also tend to recur. They tend to metastasize a little bit more easily. And unfortunately, for a lot of patients who have HER2 positive metastatic breast cancer, they often will have a lot of like lung and liver involvement. So I talked a lot about how triple negative breast cancer tends to like to spread to the brain and other bones and things like that. The same is true for HER2 positivity. It really likes to just kind of again hit the liver and the lungs. So that's one of the reasons why we really like these two medications. Now, if somebody fails them, we now have other medications. In fact, we have a new medication called Enhertu, and we also have Kadcyla, which I talked about a little bit as well. And some of those drugs are available for patients who actually fail trastuzumab. So we're starting to have more multiple line therapies that are anti-HER2 because we know that it's an area of need. All right. Any other questions before I move on?
But doesn't that medication cause left ventricle like cardiotoxicity as well?
Yeah, it does. Exactly. And that's one of the reasons why, well, specifically, I mean, they both can. But we tend to see more of that really with trastuzumab, because pertuzumab we don't ever give by itself. So pertuzumab acts synergistically with trastuzumab, but you'll never see, a patient just on Perjeta, for example. They'll always be on Herceptin, Perjeta, or Herceptin. And we monitor for, left ventricular ejection fraction changes at baseline, and then usually every 3 months thereafter. But remember, I mentioned in the lecture that some providers don't take it that seriously. And so they'll be like, oh, we can do it every 6 months, we can do it every year. But the problem is, if you do that, then you can't really see if somebody's trending down. And it's harder to figure out like the percentage drop, right? Because you don't have to know the percentage drops necessarily for the HER2 therapies, because that's too much. But I wanted you to see that we have cutoffs for, hey, look, if it drops more than 16%, how are you supposed to know that unless you've been doing serial echoes or MUGAs, right? So
if pertuzumab wasn't in that question, the answer would have been false? Or would it have been true?
No, so it's additional.
Okay.
The term that you want to kind of pay attention to, is additional cardiotoxicity. So what I was trying to get at is combining these two meds don't mean that you have additive cardiotoxicity, but a lot of people assume that.
Okay.
Yes, but individually, they absolutely can cause cardiotoxicity.
Oh, thank you.
Yeah, no problem. All right, so which of the following...
Quick question, Dr. Leyva.
Yeah, sure, what's up?
So I remember reading or listening to your recording about how when we add trastuzumab with Perjeta, that we monitor the LVEF.
Yep.
But why is it like, I remember it was like 16% for trastuzumab, but then why is it when you combine it, it's only like 10%? Why is it lower? You would think it would be higher, no?
Right, exactly. And that's kind of where the rub is. We don't understand why combining two cardiotoxic drugs doesn't make it more cardiotoxic. So, there's no good answer for this, but we do know that if you give somebody trastuzumab on their own, this is the hold parameter or the, area of concern that we have when it comes to a drop in baseline. I think the reason why the 16%, okay, so I think your question is really, why is there a lower threshold, right, for withholding with the both? And it's again, because we assumed from the studies when we were creating the clinical trials, we assumed that there would be more cardiotoxicity. And so that lower threshold number is reflective of assuming that it's more cardiotoxic. But in reality, we know that it's not. Does that make sense?
Not really, but I still have. I'll have to accept it.
No, you don't have to accept it. This is why I answer questions, and we can take as long as we need to get through this iRAT. There is absolutely no time limit on your learning. So, and if you have a question, then probably other people do too. Okay, let me see if I can rephrase this. So part of this is historical. Trastuzumab came out first, okay? When trastuzumab came out, we saw that patients were having quite a bit of cardiomyopathy. And based on the studies, when they created the package insert, they decided that a 16% drop or more would be cause to withhold. Then Perjeta was created, and it was used in combination. During that study, they assumed they were going to see more cardiotoxicity, so they had a much lower threshold for withholding the medication. What we know in reality is that that's not true. There's probably about an equivalent risk. So when somebody is on a Herceptin, Perjeta, doesn't matter if they're on both, doesn't matter if they're on one, you're going to always monitor for cardiotoxicity. That's really what you should be getting out of this. Okay? So the, the point in which we stop and hold and blah, blah, blah is a little bit less important than knowing that it can happen and knowing that we have to monitor for it. And not assuming that it's going to be worse when you combine the two. Is that a little bit more clarifying?
Yeah, a little bit. Thank you.
A little bit. Okay. If you still have questions, hit me up after class. Okay. No shame in questions. All right. Are there any other questions about that? Anything that's unclear? Clear as mud? Okay. If you have any other questions, please don't hesitate to ask. All right, so which of the following medications improve quality of life for breast cancer patients with bony metastasis? Any takers?
Denosumab.
Denosumab, exactly. In terms of like equivalency between denosumab and like zoledronic acid, as I've talked about, they're both really good medications. They're both really helpful at preventing bony metastasis and also treating hypercalcemia of malignancy. But it's a lot easier for patients to just come in and get a sub-Q injection every 4 weeks, or depending on what the protocol is for that particular institution, as opposed to having to come in for an infusion. And also some of the side effects with zoledronic acid or Zometa are a little bit more pronounced. So people will often have to take like Tylenol, and then also sometimes even narcotics, afterwards, because patients will often have like a lot of bone pain after they take Zometa. Would we give alendronate? Do we talk about alendronate at all? No, right? No. We don't worry so much about the orals. When it comes to breast cancer, prostate cancer, we'll talk more about these drugs. Denosumab, pamidronate, and zoledronic acid are really the ones that we're using in this patient population. Incidentally, what side effect do we worry about with all of them? Pretty severe side effect, actually. Anyone remember from your previous forays into these drugs? If I give you a hint, like a dental. What was that?
Sorry, I was about to say something else. Was it they have to sit upright when they take it?
Oh, yes. So for alendronate, yeah, absolutely, because it can cause GI issues if you're taking it orally. But what's a major side effect that's pretty common among this entire class of medications? It's one of the reasons why we have to have dental exams. We have to make sure patients have dental exams prior to starting.
O&J.
Jaw necrosis?
Exactly, osteonecrosis of the jaw. So any one of these can cause it. When denosumab first came out, the drug makers were like, oh, it's a really low risk. It doesn't really happen. Yeah, it does actually happen. So we want to make sure that patients, a couple of things when patients are on these medications, we want to make sure that they're taking calcium with vitamin D, particularly with denosumab, because denosumab can drop their calcium very low. It is an extremely good drug at dropping calcium, which is one of the reasons why we like to use it now for hypercalcemia. And also, again, you do worry about osteonecrosis of the jaw. So we want to make sure that calcium supplementation seems to help kind of prevent that, along with routine dental care. But if somebody needs to have like a tooth pulled, for example, or they need to have any kind of oral surgery, we have to stop these medications and do essentially a washout period before a patient can have a procedure done, like an extraction, because they can end up developing osteonecrosis of the jaw, even after they've completed, even after we've held the medications. I had one patient who had been on zoledronic acid for like 2 or 3 years, and we stopped the medication, and because the patient was having some side effects. And then about a year or so later, the patient had to have dental work and still developed osteonecrosis of the jaw. So one of the things we know is that these drugs, especially zoledronic acid, it hangs around for a long time. So we don't even really know necessarily what the safest washout period is. Okay, any other questions about that? And I see our P4s have joined us, and we're still going through the iRAT. So you guys are just going to, unfortunately, have to hold, please. All right. Any other questions on that one before I move on? Okay. So one of your patients with stage 4 ER/PR positive HER2 negative breast cancer is visiting you in clinic and is complaining of nausea after beginning her new treatment regimen. Most likely she just started which drug? Anybody want to help us out?
Olaparib.
Can you say that a little louder? Sorry.
Olaparib.
Olaparib, exactly. Now, why did you choose olaparib?
Because it's used for HER2 negative and it has a high hematogenic risk.
That's right, exactly. So lapatinib, we're not going to use. Why wouldn't we use lapatinib?
That's for HER2 positive.
Exactly, perfect. What's the brand name for it?
I don't remember.
That's okay. Anybody want to help him out? Thank you.
Tykerb.
That's right, Tykerb. Now, gemcitabine, did we really talk about gemcitabine yet? Not really, right? We're going to kind of get to gemcitabine when we get to lung cancer. And also we'll talk a little bit about it in ovarian cancer. And then atezolizumab. I kind of touched on this at the end, but what indication are we tending to use atezolizumab in? Is it this molecular subtype?
It's for triple negative breast cancer, right?
That's right. So we've really started using it more for triple negative breast cancer because anecdotally there was some evidence that it might improve progression-free survival, although the overall survival endpoints haven't really been reached. So it's kind of unclear at this point. Also, do you remember if atezolizumab tends to cause nausea from our discussion on anti-emesis? So what kind of medication is atezolizumab?
PD-L1.
It's an anti-PD-L1, exactly. And none of those drugs really tend to have any kind of emetic risk, right? I think they're all considered minimal, so less than 10%. Exactly. But what side effect is atezolizumab likely to cause? Or what side effects? Do you guys remember from our iRAT conversation? Nobody? All right, how about NAT? What are some of the side effects that you can see from atezolizumab?
Yeah, I think it was diarrhea, isn't it?
Yep, diarrhea is one of them. Anything else?
That's all I know right now.
Okay. Anybody else want to help him out? Nobody. God, you guys are mean. I'm just kidding.
Immune-related adverse events?
What was that? Sorry.
Is it like immune-related adverse events, so like your colitis, pneumonitis?
Exactly. Just take an organ state and add itis to it, and you'll probably always get the answer right. So anything that you can think of, like encephalitis, right? Colitis, exactly. Cardiomyopathy, I guess it's not really an itis, but myocarditis, potentially. Yeah, there's all kinds of issues. Thyroiditis, pancreatitis, and potentially leading sometimes to diabetes. So yeah, we're more likely to see, we're not going to see nausea unless it's like a side effect from having like hepatitis, for example, or something like that. But its immunogenicity risk is low, or minimal rather. And we tend to be concerned about itises. Exactly. All right, any questions about that? Okay, moving on. So for the Faslodex, what is the answer for this one? First of all, is there a loading dose for Faslodex? There is, right? Okay. Which, who wants to help us out? Which answer is this?
The 250 on the 115 and 29.
Ooh, you are close. That is half the dose.
The 500.
500, that's right. So we give 250 in each butt cheek, right? For a total of 500. So, and that's one of the reasons why I kind of harped on this as a safety issue, because even though it comes in a 2-pack, I've actually seen nurses forget to give both doses because they're like, oh, 250 days 1, 15, and 29. And then of course you do it every, 30 days after or whatever. But yeah, so it's also a really big injection. So remember I told you guys that like it's 5 mLs in each butt cheek, which is ginormous. That's a lot of fluid. The normal is about 2.5 mLs. And so most institutions will actually have like a cutoff and say you can't inject anything into an intramuscular space that's more than 2.5 mLs. And all these hospitals had to rewrite their policies except for Faslodex when Faslodex came out. And it does cause I've had patients, cry and actually have to stop Faslodex and do something else because they just couldn't withstand the pain and also some of the scarring. So what'll happen is patients will get these, really big knots on their cheeks, and it'll be hard for them to sit. And then if you're a really thin person, there's a risk of damaging the sciatic nerve. So there have been, times where people have not given the injection correctly and have done severe nerve damage to patients. So there's discussion about making this an oral form, and it hasn't happened yet, but there's discussion about it. So I'm hoping that at some point they will do that. All right, any questions on that?
Can't you give it little by little instead of just shooting up the whole 5 mils one time? Can't you divide it into more than ones, like 2 mils somewhere, 2 mils somewhere?
Yeah, you're not supposed to. Because it's a slow release medication. So you have to it is a slow injection. It's really viscous, so it requires a lot of force. I've actually helped the nurse push down the plunger before, because it's just, you get so much resistance because it's so much fluid in a small space. But unfortunately it's one poke, and you just have to continue to do it until the medication goes in. Problem is, if you pull up, you'd have to change the needle, right? And then you'd have to find another spot too that, it will have the equivalent release rate, and that's impossible. So that's why we can't. Does that answer your question?
Yeah.
Cool. Sure, no problem. Okay, so please choose the most correct statement about early stage luminal A breast cancer in a newly diagnosed 42-year-old premenopausal cisgendered female who is otherwise healthy. Anybody want to take a stab at it? Now that you're experts in luminal A and luminal B and HER2 enriched and triple negative.
Is it B? Nalvada?
It is. That's right. And what is the generic name for that?
Tamoxifen?
That's right. So she's premenopausal, right? And so we know that we can give her, so the category 1 recommendation is we give her tamoxifen. We could give her Arimidex, but what would we have to give her in addition to that?
Ovarian ablation or suppression therapy?
Exactly. And do you see one on here?
No, it's just Arimidex. Oh, but yeah, right. That one is. But
exactly.
Yeah, not with that.
Exactly. So that's why we can't do the only correct answer is this one, right? Because this is tamoxifen. This would be right if it were with Zoladex, and Zoladex wouldn't be given on its own. And Faslodex, do we use Faslodex in early stage breast cancers?
I think after everything failed, you can use that one. So first you try.
Yeah, and I would say I've never seen it used in early stage breast cancer. So if you failed everything, you're probably at stage 4, unfortunately.
Yeah, so then you use it.
Exactly. Perfect. That's great. Okay. Any other questions? You guys good on that? Okay. Just so you know, that's about the extent of the kinds of questions that I'll ask when it comes to the hormone therapies, just because it gets way too confusing. So if I start asking questions like, would you do tamoxifen for 5 years and this for 2 to 3? I'm not asking anything like that. I just want you to know, if you're premenopausal, you can just give tamoxifen. If there's a problem with giving tamoxifen, you can give Arimidex or, the AIs, but you have to always give it with ovarian suppression. That's it. That's pretty reasonable, right? Okay. And then if you're postmenopausal, we can do either, and we don't have to worry about ovarian suppression. So sometimes the choices to decide, about tamoxifen or one of the other agents is really just about personal preference, what their insurance covers, and also like what other comorbidities they might have. Again, somebody who has a really high risk of thrombotic events, then we have other options. Somebody who has really high risk of osteoporosis or already has osteoporosis. All of these agents can cause osteoporosis or worsen it. And so often what we'll do is we'll just have to add an adjunctive medication like Reclast, right, which is the other form of zoledronic acid, or potentially something called Prolia as well to help prevent osteoporosis. But in general, that's really how we separate out premenopausal, postmenopausal. You guys feel comfortable with that? Excellent. Okay. So an oncology fellow sends a chemotherapy order for ixabepilone. What's the brand name for ixabepilone? I just like saying it. It's kind of fun. Has like pep in its step. Yeah.
Example.
Exactly. All right. So for one of your patients who has T3, N2, M1, incidentally, what stage is that? This should jump right out at you.
Stage 4.
Stage 4.
Right. And why is it stage 4?
Metastatic.
Right. It has an M1, right? So that's a nice, easy way for you to know. That's why on the exam, you guys rocked that question. Because again, we put in that M1 here. Okay, so this drug is sent to the pharmacy for verification. As you're reviewing the patient's chart, you see that she previously had an allergic reaction to paclitaxel. So what is paclitaxel? What kind of drug is it? What's its MOA?
Mitotic inhibitor.
Exactly. And so is ixabepilone, right? Okay. What do you do if you know that a person has had a previous allergic reaction to paclitaxel? Are we going to refuse to fill the order because it's contraindicated?
Yes.
I see some people shaking their heads. So, okay. I heard one yes too. So it seems like we're a little divided here. Okay. So let's look at some of our other options. Fill the order, but pre-medicate with an H1 or H2 blocker. We do that for Taxols, right, or taxanes often to prevent allergic reactions. Fill the order as written, or refuse to fill the order because of her stage. Well, we know that she's stage 4. That's appropriate. But here's the thing. Ixabepilone is actually formulated with Cream-4-EL. Does that sound familiar? What else has Cream-4-EL in it?
Taxane products.
Well, yeah, specifically paclitaxel, right? So docetaxel has a slightly different formulation. It's something called polysorbate 80. But we know that ixabepilone is made very similarly to Taxol or paclitaxel, right? So if you have a severe allergic reaction to paclitaxel, the last thing I want to do is give somebody ixabepilone. So this would absolutely 100% be contraindicated. Okay? All right, any questions?
Dr. Leva, if it was just like a mild reaction, can we just give them an H1 or H2 and then just monitor them and call it good? Or is it still contraindicated?
So with a mild reaction to paclitaxel, we're usually going to continue paclitaxel because we can normally pre-medicate against that. But if they've had a pretty substantial allergic response to paclitaxel, even despite pre-meds, we're definitely not going to want to give it. And we do have other options too. So we have, the option to give somebody Abraxane instead. And there are plenty of other medications or chemos that we could use for stage 4 breast cancer. I didn't show you guys the whole list of like the salvage therapies, but there are many lines of therapy that you can actually go through if you have an allergy. So most people don't really want to chance it. And also the other thing is if someone's coming from a different location, so let's say somebody's getting treated at like, MD Anderson, and then they move to your facility and you're taking a history from the patient and the patient says, oh yeah, I had a really bad reaction to paclitaxel. At that point, I'm just going to take their word for it probably. And it may have only been a mild one, but I don't want to risk potentially them having a life-threatening event. Does that make sense?
Yeah, thanks.
Cool. Yeah, that was a great question, by the way. And there is a lot of nuance to some of this stuff. So again, we'll just usually use another medication. All right. Your newly diagnosed patient is 45 years old and still reports regular menses. She was diagnosed with stage 2 breast cancer several weeks ago and will need to undergo surgery and then chemotherapy. Her oncologist wants to know what you would suggest for adjuvant endocrine therapy and when she should start. Okay. So, can somebody help us out? Oh, and happy birthday, Raymond. Sorry, I just saw that now.
Thank you.
Do you want to help us answer this question? That would be not fair, actually. Put the birthday boy on the spot. Is there anybody else who would like to answer this question? Anybody want to try? How about Paul? Can you help us out? Oh, I think you're on mute. There we go. Yes.
The last one, I think.
Okay, so you chose Arimidex plus Leuprolide upon completion of chemotherapy. That is correct. And can you walk us through why?
I wasn't sure because
you definitely nailed the question. That is, in fact, the right answer. Is there anybody else who wants to help out? How about Thomas? You want to help us out? So why does Arimidex and Leuprolide make sense for us?
Not sure, I got this one wrong.
Okay. So which one did you choose? Let's work backwards.
Let's see, on yours I picked A, but I wasn't sure.
Okay. All right. So she's 45 and she's still having her period. So if she's 45 and still having her period, what does that mean? Is she premenopausal or postmenopausal?
Yeah, premenopausal.
Right, exactly. So if she's premenopausal, we know that we can't give Arimidex by itself, right? So that immediately knocks out this answer choice. The other part about this answer choice that's wrong is that we want to make sure that we start this adjuvant endocrine therapy after somebody is done with surgery and chemotherapy, okay? Part of the reason we do this is because the last thing we want to do is give somebody more side effects when we're already putting them on pretty yucky chemotherapy, right? So we know that patients are much better able to tolerate the medications if we start them after they're done with surgery and chemotherapy. So that's why this particular answer doesn't work well. This one doesn't work well because we don't combine an AI and a SERM ever together like this. So that's why this would be duplicative therapy, right? But the upon completion of chemotherapy is right, for sure. And then tamoxifen upon completion of surgery, same problem as this, right? We want to make sure that we don't start these therapies until after the patient has had surgery and then chemotherapy, right? So in this case, they're having adjuvant chemotherapy because it's happening after they've had surgery. If they had chemotherapy before surgery, what would we call that?
Neoadjuvant.
Exactly, neoadjuvant. Okay. And then that arrives at our last choice, which is the correct one, and that is Arimidex plus Leuprolide, because we want to make sure we're doing this ovarian suppression, because we're giving the person an AI upon completion of chemotherapy. So that means after they've finished surgery and chemo. And then they can go ahead and start their 5 years basically starts at that point, where their time on adjuvant endocrine therapy starts from the moment that they're done with chemotherapy. Does that make more sense about why, Paul, you chose that? Yes. Okay, cool. All right.
Dr. Leva?
Yes.
Explain why C was wrong again.
Yeah, so C is wrong because the drug itself is correct. I have no problem with giving tamoxifen. And that's usually a preferred treatment option for a premenopausal woman. But we haven't waited until the completion of chemotherapy. And so we know that when we combine tamoxifen or Arimidex plus chemotherapy, it usually accentuates the discomfort of being on chemotherapy. So, for example, one of the common things that happens for patients when they receive chemotherapy is they get a lot of joint pains and myalgias, arthralgias, things like that. If I give somebody something to suppress their hormone production even more, that tends to deepen those side effects. So patients are very uncomfortable, and they can also potentially experience more cardiotoxicity, more thrombotic events. So we just know that it's not a good idea to start those therapies at the same time. And it's also a little bit easier for patients too, because if you're giving them all this medication at once, they have to be compliant with all kinds of things, right? So if you're giving somebody chemo, it might be a metagenic. So then you've got to worry about them taking, Zofran and Compazine and all this other stuff at home by mouth, right? And they have to have it scheduled. And then they're also on the regular medications because a lot of these patients have diabetes and asthma and, other things, right? Because cancer doesn't exist in a vacuum. So to add a new daily medication to somebody, or maybe multiple or whatever it is, makes it hard for patients to stay on track. So this is a much easier way for clinicians and patients to keep track of starting that adjuvant endocrine therapy.
So for C to be right, it will be tamoxifen after chemo.
Exactly.
Okay.
Mm-hmm. Now, if chemo were neoadjuvant and then the patient had surgery, then that would be a correct, right? Because they've completed their therapy. So if they had neoadjuvant chemo, had surgery, and then didn't need to have any more chemotherapy, then patient's done and they're going to go ahead and start the adjuvant endocrine therapy. It's just wrong in this case because they're getting adjuvant chemo, not neoadjuvant chemo.
Oh, okay, that makes sense.
Mm-hmm.
For D, so D is right. That's the
this one. Yep, Arimidex plus Leuprolide, because again, ovarian suppression, right? We don't want their ovaries to keep dropping eggs like it's hot. We want that to stop because that helps increase their exposure of estrogen, and we don't want that.
That's the category 1 recommendation, right? On the guideline.
Yeah. I mean, tamoxifen and Arimidex plus, or an AI plus some kind of ovarian suppression. Yep.
Okay, thank you. And a quick question on the previous question. I just want to confirm: will we refuse because it's contraindicated?
Yes, you're going to refuse to fill the order because it's contraindicated. Exactly. Because if you have a cross allergy, it's kind of like penicillin and amoxicillin. You think of it that way, right? If you have a severe allergic reaction to penicillin, you're not going to want to give amoxicillin. It's kind of the same principle with paclitaxel. Yep.
Okay, gotcha. All right, thank you.
Awesome. Mm-hmm. Okay, a woman on tamoxifen who has intact reproductive organs. What does that mean? Is it just like a weird thing for me to say, or what image does that conjure up for you?
That they still have their organs. No.
Right. So specifically,
they haven't gone through ovaries.
Yep. And we're going to learn all about hysterectomies next week, or this week actually, when we do ovarian cancer. But so intact reproductive organs means a woman has not had an oophorectomy. which means removal of ovaries, or a hysterectomy, removal of the uterus. Cool. Okay. So a woman who has intact reproductive organs, what should she be monitored for in terms of ADRs? So would we monitor for vasomotor symptoms? What's a common adverse drug event for tamoxifen?
Hot
flashes.
Hot flashes. What is our other term for hot flashes?
Vasomotor symptoms.
Yeah.
Exactly, vasomotor symptoms. So yes, we do monitor for this because this is an important quality of life issue for some women, right? Like, you know, we've heard a lot of women joke about like, oh, I'm having a hot flash, whatever, but they're not fun. And patients will stop taking tamoxifen because of the vasomotor symptoms for some patients. So, you know, we definitely want to monitor for this because it may necessitate us switching to another medication. Now, the vasomotor symptoms may not necessarily improve if we switch to an AI, but sometimes they do, especially when we also add that ovarian ablation or suppression. So vasomotor symptoms, absolutely. What about thrombotic events? Do we worry about that?
Yes.
We do. And so what kind of thrombotic events are we talking about?
DVT, PE.
And what's the big one?
Stroke.
Stroke, yep. And where else can we get clots and can cause long-term damage?
MI.
Yeah, exactly, an MI. So we want to, you know, monitor patients for that. What else? So hypercholesterolemia, do we worry about that? Do we do lipid panels?
Yes.
Yes.
Mm-hmm. That's right. Now, we do lipid panels in part because we know that lipid panels and thrombotic events are also linked, right? So if a patient who's thrust into early menopause, which creates artificial menopause for patients who are premenopausal, or it deepens menopause for women who are postmenopausal. So, sorry, there's weird sounds in the house. It's not my dog or my cat. Anyway, so we know that when that happens, patients have an increased risk potentially of having an MI or other kinds of events. So we want to ensure that we're monitoring their cholesterol, and if their cholesterol is climbing, then we may even consider adding in a statin, and we'll do a low intensity or medium intensity, high intensity, depending on what their cardiovascular risk is and also what their levels are. So I just want you to keep in mind that, again, when we deepen menopause or start menopause in a person, we're changing their hormone configuration and we're potentially increasing their risks of all kinds of different events, osteoporosis, MI, other thrombotic events, etc. Does that make sense? Cool. Okay, and then, so we know we have to check a lipid panel. And then what about uterine sarcomas?
Yeah.
Do we worry about that?
Yeah, because they're a higher risk of endometrium cancer, 2 to 3 times risk with tamoxifen.
Exactly. So, you know, there are some women who we decide, you know, the safest thing to do, especially if we know that their particular type of breast cancer is very, very hormone rich, and their oncotype scores are much higher. There are times where we will suggest potentially patients having a prophylactic hysterectomy just to protect them. And also patients who have BRCA mutations, BRCA1 or 2, we might also recommend that to prevent ovarian cancer and some of the other types of reproductive cancers that can happen. Excellent. Okay, so any other questions about this particular iRAT? I know it took us a long time, but I really wanted to make sure, this is a big topic, so I really wanted to make sure that you guys felt comfortable as much as you can with this topic. And I think a couple of you may have messaged me privately about an issue with an iRAT. So please follow up with me after class or send me an email, just because it's hard. Sometimes in the chat, I might see it, but then as I'm teaching, I'll lose track. So I don't want to forget about any of you. So if there is something that you need to let me know, please send me an email and I will respond. Okay, so if there are no more questions, here's the plan. I'm going to break you out into your groups, except for my P4s.